Good afternoon. Can you all hear me?
Good afternoon, madam. We can hear you, madam.
Okay. Can you see the slides also?
Yes, madam.
Okay. I mean, if you can see the slides changing, if you can't see, please let me know. Now I'm going to start, okay? I know that there's low number, but I'm going to start on time, okay? Now, today we are going to start, I think last week's lecture, we discussed about soft tissue rheumatological problems. Now, from today, few lectures, we are going to discuss about real, kind of mainly collagen vascular diseases that you might see commonly in the wards. Okay, now next slide, there will be three different presentations that I have just put it on the slide. First one, 46-year-old married teacher with 3 school-going children, presents with painful swelling of both knees, elbows, and some of the joints in the fingers and toes for 3 to 4 months duration. She has realized that pains are more in the morning as she wakes up, and some days the whole morning her joints are stiff. Now, I'm not going to ask you questions because you don't answer, and I have no way of getting you to answer because you are not with me. Okay, so however much I ask you to answer, you will be silent. I know that. Okay, now I would highlight the points, highlighting points. Now, this is a 46-year-old person, married teacher. So she's married, she's working, and she has 3 school-going children. Okay? And she has involvement of knees, elbows, their large joints, and some finger joints. Okay. Now, 46-year-old married teacher does not say whether this is he or she, but the next line starts with she, so you know that it's a female. So it's a 46-year-old female patient presenting with large and small joint involvement of 3 to 4 months duration. And there is morning increase in her symptoms, and there is morning stiffness. Okay, what does this indicate? What are the significances of these given points? One thing is that she's a kind of a 46, you call it middle-aged female patient. So what are the diseases that you rheumatological problems that you commonly get among middle-aged female patients? And the other point that she has involvement of large and small joints, and it is a shorter duration, not acute, but it's kind of a subacute onset, not chronic, subacute onset. But what you need to remember, these patients might not present to you for the first time, so you might even see a patient with chronic arthropathy, or you might sometimes can present with very acute problem. This is generally a common presentation. And she has morning stiffness. What is the significance of morning stiffness? Morning stiffness indicates that there is inflammation. You know that pain can be due to just trauma can cause pain. Mechanical problems can cause pain, but most of the time those pains are due to after work. They get worse towards the evening. But importance of inflammatory pain is worse when you rest. So morning is important because people rest in the night, and when you wake up in the morning, that you are stiff. So that indicates there is possibility of inflammatory origin for this arthritic problem. But that depends on the patient's the time that patient sleeps. Say that somebody, a security officer who is up in the whole night and he sleeps during the daytime, so he might not have morning stiffness. He might develop the stiffness when he sleeps during the daytime and wakes up in the evening, he might develop stiffness. So we call it morning stiffness, it is stiffness after a period of rest. Now, these are the important things that I highlighted. Okay. Now, next one. Now, these kind of cases we'll be discussing in next 3-4 lectures. Young female, schoolgirl, 18-year-old schoolgirl, loss of weight, evening fever, aches and pains of the body, ulcers in the oral cavity of 3 weeks duration. This duration is shorter than that, with kind of general kind of symptoms. Weight loss, evening pyrexia, aches and pains, not very specific. They are not specific. And mother says that she is losing her hair unusually and she has some red patches on her face. And, sorry, this is arms, of 2 weeks duration. So there's nothing much to say that there's joint involvement, but she has generalized symptoms. She's losing hair and there's skin involvement and oral cavity. So oral, mucosal and skin involvement. Okay, now the highlighting points are that's a young, again female, with these vague general symptoms, plus most of the things are general, but some evidence of mucosal skin and scalp involvement. Then the third one, 50-year-old female presents with painful fingers during cooking and washing clothes. She also was worried about some unusual thickening of her skin, white patches behind her neck, and difficulty in opening the mouth. I think you have started clinicals, must have finished your rheumatology appointment. So you must have finished some medical appointments. So you would have seen some of these patients. Again, middle-aged female patient, painful fingers during cooking and washing. Cooking and washing, you are exposed to water. Water is generally cold. So when you are exposed to cold, you develop painful fingers. And in addition to that, she has noticed some thickening of the skin and some white patches. These things we will be discussing later on when we do the relevant diseases. Okay. Now here the important things, again the age, being female is important. Painful fingers. Fingers are painful during washing. Okay. And thickening of skin, white patches, and she finds it difficult to open the mouth. What is the reason? It can be something to do with the temporomandibular joint, can be some problem in the teeth, or can be some problem in the oral mucosa or the mouth cavity. Okay, now if you take this, if you chart their presentations, most likely diagnosis in the first case can be rheumatoid arthritis. Second case, it can be systemic lupus erythematosus. And the third one, it can be scleroderma. But you need to remember, though we discuss these cases separately under different headings, sometimes some patients can present with mixed features. There might be a patient with features of rheumatoid arthritis mixed with some features of SLE and few features of scleroderma, or predominantly scleroderma features, but might be having some rheumatological problems. So then these diseases can be mixed. Okay, so you call it overlap. Their features can overlap. We'll be discussing these things later on. So we'll start with rheumatoid arthritis. I think you would have seen this kind of hands in medical wards, in rheumatological wards, and in the clinics. You would have seen this kind of very deformed hands. Okay. Now, the rheumatoid arthritis is about 1% of adult population you get, and mainly females are affected. Mainly middle-aged females are affected. But what you need to remember, can occur at any age and males can get affected. Okay. Important things are common. The common presentation of rheumatoid arthritis, usually a female, middle-aged female. Usual presentation is with bilateral symmetrical polyarthritis involving large and small joints. So remember, usual presentation is bilateral, symmetrical, large and small joint arthritis. But that doesn't mean you can't get only large joint involvement, only small joint involvement, or sometimes even with unilateral presentation. Those can be not less common presentations. And the common joints are proximal interphalangeal joints, metacarpophalangeal joints, wrists. Okay, those are the common joints mainly when the small joints are affected. Proximal interphalangeal joints. Remember, not distal interphalangeal joints. There can be other diseases where you commonly see distal interphalangeal joint involvement. But in rheumatoid arthritis, mainly it is proximal interphalangeal joint involvement. Though we call it rheumatoid arthritis, it is not only an arthritic condition. It is a multisystemic disease. Okay, it can involve any system of the body. So it is not just arthritis only. It can affect any system of the body, and not only it can affect any system of the body. Sometimes the first presentation can start from any system rather than with arthritic manifestations. Okay, if you have any problem, you can unmute your mics and question me. Okay. Now, the commonest joints are proximal interphalangeal joints, wrists, and then I think you can, this picture shows you the percentages, how the joints can get involved, metacarpophalangeal joints, and in the feet also, metatarsophalangeal joints, ankles, subtalar, then little less commonly, knee joints, and you can get even joints like temporomandibular joint. Spine too can get involved in rheumatoid arthritis, but most of the time it is cervical spine rather than the rest of the spine. But what you need to remember, there are certain other diseases you get commonly involvement in the rest of the spine. Okay. And what happens is how they develop the deformities. These joint involvement will cause erosions in the joints. There is synovial involvement, synovial thickening, inflammation, and ultimately joint erosions, and there will be joint deformities. But we should not wait until they develop these erosions to diagnose rheumatoid arthritis. Okay, so you need to find, there are some very characteristic appearances, characteristic joint deformities that you get in rheumatoid arthritis. Go home and find out what are these. So you must not finish learning about rheumatoid arthritis from this lecture. Go home and read a textbook, and you can see that there are many different types of characteristic lesions with typical names given for those deformities. Okay, now these are the common deformities that you get in rheumatoid arthritis. And I think if you see now, you can see that there is ulnar deviation of in the hands, and you can see metacarpophalangeal joints are involved, and here you can see the flexion at the distal interphalangeal joint and a hyperextension at the proximal interphalangeal joint. Okay, you can see this is like formation of Z shape in the thumb. You call it Z thumb. Okay, and here the same lesion what we have seen here, extension at the distal interphalangeal joint, flexion at the distal interphalangeal joint, extension at the proximal interphalangeal joint, and you call it swan neck deformity. But the other one, flexion at the proximal interphalangeal joint, you call it boutonniere deformity when it is bent at the proximal interphalangeal joint. Okay, so there are different lesions, that these are the common lesions that you get. Go home and read about deformities in rheumatoid arthritis. And rheumatoid arthritis, though it's mainly arthritic problem, they can present with many non-specific manifestations, and you call them constitutional features. In any disease, you can get these constitutional features, like in malignancies and in other collagen vascular diseases, you can get these constitutional features. They are non-specific and usually lethargy, that you don't feel well, loss of weight, loss of appetite, night sweating, fever. Those are the constitutional symptoms. So patients can present with arthritic manifestations, patient can present with evidence of other organ involvement, or patient can just present with non-specific constitutional symptoms. So if you cannot, if somebody presents with non-constitutional symptoms for some time, if you cannot find a cause like infection, malignancy or anything, this is something that you need to think of, whether it is a collagen vascular disease, even if there is no evidence of arthritis. Now, as I mentioned, that though it is called rheumatoid arthritis, it is not only with arthritis, there are extra-articular features. There are constitutional features, those are non-specific, and there are extra-articular features. These extra-articular features again can be non-organ specific, not specific to an organ, like non-specific things. Then there can be organ specific. Some systems can get involved, like vascular system, cardiac system, pulmonary, renal, neurological, hematological. Any system can get involved in rheumatoid arthritis. Okay, now if you list out extra-articular features of rheumatoid arthritis, non-organ specific, as we discussed earlier, all constitutional symptoms are non-organ specific, like weight loss, malaise, fever. They can have generalized lymphadenopathy. Then there can be rheumatoid nodules, subcutaneous nodules. They are not usually painful. Then there can be Felty's syndrome. Felty's syndrome is they can have splenomegaly with thrombocytopenia due to splenomegaly, hypersplenism. And then because it is a chronic disease, they can develop amyloidosis, secondary amyloidosis. And they also can have Zika syndrome. I don't know whether you have heard of Zika syndrome. Zika syndrome is due to involvement of the exocrine glands. So exocrine glands involvement, that is like salivary glands, lacrimal glands. These people usual presentations are with dry eyes and dry mouth. Those are non-specific involvements. Then they can develop due to vascular system involvement. They can develop splinter hemorrhages. So remember that splinter hemorrhages are not seen only in infective endocarditis. Any vasculitic condition, including rheumatoid arthritis, can cause splinter hemorrhages. Then distal gangrene, again due to vasculitis. Nail fold infarcts, cutaneous ulcerations, palpable purpura. Then not only the skin, other organs, there can be vasculitis, and there can be mesenteric vasculitis. Then pulmonary, episclera, there can be vasculitis, sclera, there can be vasculitis. So all these manifestations can occur. Then if you take cardiac system, almost any layer, all three layers can get affected. So there can be pericarditis, which can cause constrictive pericarditis, or there can be muscle layer involvement. So there can be myocarditis, there can be endocarditis. So all three layers can get affected. So there can be pericardial problems, there can be conduction problems, there can be endocardium involvement, there can be valvular problems. Again in the lungs, again any layer of the lungs, any system, any kind of structure in the lungs can get affected. So the pleura can get affected, pleural effusions can occur. Then lung itself, parenchymal lung disease can happen. There can be interstitial fibrosis, there can be nodules in the lungs. Then the air-based system can get affected, so they can have bronchiolitis, and there's vasculature in the lungs. So there can be arteritis. So any structure in the respiratory system can get affected in rheumatoid arthritis. Then kidney. Kidney can get affected not only by the disease. Kidney can get affected by the disease as well as by the drugs, because you will be giving a lot of non-steroidal anti-inflammatory drugs for these people. So they can get non-steroidal anti-inflammatory drugs induced renal disease, and there are disease modifying drugs. All these drugs can cause effects on kidneys. In addition to that, the disease itself can cause various types of glomerular nephropathies and renal tubular diseases. And due to, as I have mentioned earlier, chronic illness can cause amyloidosis. Amyloid deposits can cause chronic, again, kidney disease due to amyloidosis. Then nervous system. What can happen in the nervous system? Again, anything can happen. Compressive neuropathies can happen due to joint deformities like carpal tunnel syndrome, tarsal tunnel syndrome, due to deformities. Then again, cervical, because of the cervical spine involvement, there can be cervical myelopathy. So there can be pressure on the spinal cord. So those are the compressive neuropathies. Then there can be, due to vasculitis, there can be peripheral neuropathy. And rheumatoid arthritis can be 10% of the patients can develop rapidly progressing disease. There can be patients, just one episode, they flare up and they are treated, and after that they respond to the treatment, and they usually remain without symptoms. But most of the people will have common presentation is chronic progressive disease. Okay, if they are not treated properly, most of the people will be disabled in few years' time, and their life expectancy can be reduced because of the multisystemic involvement. And what you need to remember is these diseases, if you want them to have good life, you need to start them on diagnose early and start them on treatment early, because if you delay treatment, they can develop persistent problems. They can develop erosions, deformities, and that can affect their function. And if you leave untreated with disease modifying drugs, by about 1 year, they can have erosions and deformities. So what you want to prevent is them developing deformities. What are the factors which will tell you that this patient's prognosis might not be all that good? Now, usually it's a middle-aged female, but sometimes it can occur a little late. In 60s, 70s, it can start. When it starts a little later, you can have not very good prognosis. Anyway, females get it commonly, and their prognosis is not very good. And if you have involvement of, when the patient presents with multiple involvement, with many joints involvement, then the prognosis might not be very good. And if you find it very difficult to control, sometimes when you start them on treatment, they respond to treatment fairly quickly. Such people, prognosis can be good. But if you find it difficult to achieve response to treatment, then prognosis might not be all that good. And the other thing is, if by the time that you get the patient has already developed deformities, erosions, then prognosis, because it's already damage is done, then the prognosis might not be all that good. And the other thing, that if there is already functional disability, because of the disease, functional disability is established, then the prognosis might not be good. And rather than not having extra-articular manifestations, when you have extra-articular manifestations like Other than joints, if you have cardiac involvement, lung involvement, kidney involvement, then the prognosis can be poor. And like in any other disease, poverty, lower educational level, heavy manual work, somebody is involved in, it's a laborer, it can be poor prognosis, because anyway that he might find it difficult to stop working. So he might get involved in activities that can cause problems to his joints. And low educational level, he might not understand the extent of the problem, and he might not, his compliance might not be good with the drugs. And poverty, anyway, any disease outcome is going to be lower if your social class is lower, if your understanding is lower, and if you are poor. And if the patient has higher levels of rheumatoid factor at the beginning, again, prognosis can affect prognosis. And if you have presence of HLA DR3, again, prognosis can be bad. Now, this criteria that I have shown in this slide were the criteria to diagnose rheumatoid arthritis. These were developed in 1988 until very recently, 2010. They were the criteria to diagnose. Now, if you go through this, morning stiffness, arthritis of more than 3 joints, arthritis of hands, symmetrical arthritis, rheumatoid nodules, positive rheumatoid factor, radiological changes, extra-articular osteoporosis, and erosions. So you need to have at least 4 of the above things to diagnose rheumatoid arthritis. But then later on, they realized it is too late when you fulfill these criteria. If you need to have 4 of these, and if you need to wait until patient develops erosions, you are too late. You have already got bad prognostic factor. So then they revised the criteria and developed new criteria in 2010. 2010, these are the new criteria. They are based on 4 factors. They are based on joint involvement, serology, that is rheumatoid factor, anti-citrullinated peptide antibody. Then acute phase reactants like ESR and CRP, and the duration of symptoms. These are the 4 factors. On these 4 factors: joint involvement, presence of serological factors, whether acute phase reactants are elevated or not, and the duration of the symptoms are taken to as diagnostic factors for rheumatoid arthritis. So it's A to D. Okay. So now if you take A, joint involvement, if only 1 large joint, you give 0, 2 to 10 large joints, 1, 1 to 3. So you can see that small joint involvement has a heavier weight than large joint involvement. And 4 to 10 small joints, you give 3. More than 10 joints, you give 5 marks. So small joint involvement carries higher weight. Then serology, negative, whether it's rheumatoid factor negative, ACPA negative, low positive 2, high positive 3. Rheumatoid factor and ACPA, I think you would have heard about this, and these things, all these things can come as MCQs in your common MCQ paper. And if the CRP and ES are normal, next one, acute phase reactants. If ESI and CRP are normal, you give not. If abnormal CRP or abnormal ESR, one of those, you give 1. And duration of symptoms, if less than 6 weeks, you will wait, you give no. If you more than 6 weeks, you give 1. Okay, so these are the joint involvement, serology, acute phase reactance, duration of symptoms. If more than 6, only on joint involvement, you can get up to about 5. If there are more than 10 joints involved, you can straight away get 5. If there are more than 10 joints involvement with high ESR, you have already fulfilled criteria. Okay. So depending on that, if there are more than 6 out of 10, so here erosions have not come. You don't wait until erosions come. So it is just joint involvement, positive serological factors, and acute phase reactance with duration of the illness. Score of 6, more than 6 out of 10 is needed to diagnose rheumatoid arthritis. Okay. Then once you have diagnosed, you need to assess the disease activities. There are many criteria to many ways that you can assess disease activity scores. We commonly use disease activity score 28. That is on 28 joints, you see the disease activity. These are other things. You can just know that there are things, you don't have to know everything. I will just little bit explain disease activity score 28. And there's a calculator in the net. If you put DS28 calculator, you can get it, and you can get the count, the score on that if you enter your figures. Now here, when you see the patient, you count the number of joints out of 28 joints. That depends on you either start from the hands or feet. If the hands are more involved, you start with hand joints. If the feet are more involved and hands, no problem, you start with feet joints. Mainly, the most common presentations are the hand joint involvement. So usually you need to calculate the number of joints involved in the hands. So you count 28 joints on both sides. Number of tender joints, you see whether the joints are tender. Second thing, you see whether the joints are swollen, and then you see the ESR value. And then you add on to that patient's assessment of well-being. How does the patient feel? You 0 to 100 on a visual analog scale. Sometimes it is very difficult to ask the patient to tell. Sometimes people who do not understand that kind of thing, you might find it very difficult to get an assessment of this visual analog scale. You need to draw a line. Now this is not, this is 100. 100 means that you have a lot of problems, a lot of pains, a lot of difficulty. Not means you are completely all right. Now where do you think that you stand? And some people understand this. There can be patients who don't understand this. Okay. So these are these large joints. Can you see the enlarged picture of the now this hands, and then you start from hands and you include all hand joints and the knees. It comes to 28 joints. You see how many are tender, how many are swollen, and then ESR count, and you ask the patient's general well-being, whether it is closer to 0 or whether it is closer to 100 or in between. Like that. Then you put that on the calculator and get a score. Okay, so this is how you decide on this thing, that this, I mean, it is self-explanatory. So you assess this first visit. When you get next visit, you can assess. Then time to time, you can assess and see whether the patient is improving. Now, how do you investigate these people? Now, any disease, you investigate the patient to diagnose the condition. There are diagnostic investigations. There are investigations that would support the diagnosis. They are not diagnostic, but that they will support the diagnosis. Then you see do the certain investigations to see complications of the disease. Because of the disease, whether their patient has developed any complications. Then when you follow up, you again investigate the patient to see whether there are side effects due to drugs and whether there are complications, new complications developing due to the disease, and whether, like ESR, acute phase reactants, whether the patient is responding to your treatment. Now, if you in a rheumatoid arthritis patient, WBC count can be elevated. WBC count can be elevated, and important thing is they can have, during the active disease, they can have high platelet count. That indicates active disease. So remember, thrombocytosis or high elevated platelet count indicates inflammation. And most of the time, these patients can have anemia, and mainly it is normochromic normocytic anemia. So they can have elevated ESR, elevated CRP. They can have positive rheumatoid factor or anti-citrullinated peptide antibody. There can be positive anti-nuclear factor. And if you aspirate the joint fluid, they can have straw-colored joint fluid with increased neutrophils. But you need to remember, they can have positive rheumatoid factor, they can have positive ACPA, or their serology can be normal. With negative serology also, patients still can have rheumatoid arthritis. Other than that, you might do other investigations as baseline investigations, because you know that these people can develop multisystemic involvement. They can develop cardiac, lung, and many other involved. So you do these things and keep later on, when they change, you know that the disease is getting into other systems too. Can do a ECG, because I told you that myocardium can get affected. There can be conduction problems. Can do a chest X-ray, because there can be pleural involvement. There can be lung parenchyma involvement, lung fibrosis. Ultrasound abdomen, there can be splenomegaly, renal, liver functions, because they all can get affected due to disease and as well as to drugs. You might later on, you don't always do, but you might later on, if the patient is symptomatic, you might do HRCT, that is high resolution CT scan, to see whether there is lung involved. And you might do echocardiogram to see whether cardiac structures are involved. Okay. And management of the rheumatoid arthritis, you need to be very aggressive and quick in the management of rheumatoid arthritis. As I have told you, that they can develop erosions and develop deformities fairly early. Because of that, you need to start them on treatment early and aggressively. And usually, rheumatoid arthritis can cause arthritic manifestations, other system involvement, and they can develop deformities, they can become disabled. So your management plan should include multidisciplinary approach. So the most important thing to remember is, once you diagnose rheumatoid arthritis, you need to start them on treatment immediately, okay, to prevent future deformities and future complications. So if your diagnosis is rheumatoid arthritis, you are not going to give NSAIDs, wait and observe policy. You are going to start them immediately on disease-modifying anti-rheumatoid drugs. So the principles of management are: you relieve pain, you need to prevent them developing deformities by preventing them developing erosions, and ultimately your aim is to maintain normal function. Okay? So you educate them, you must educate them regarding the disease, is possible prolonged course and possible problems if they do not adhere to the treatment regime. Then you must encourage them exercise. You must never encourage them to rest in bed. Then physiotherapy, dietary advice to maintain ideal weight, to not to be obese. Then regarding drugs also, you need to discuss with these patients. You need to discuss with patient and maybe patient's relatives also. Okay? And they need to do regular range of motion exercise to these joints, because these joints can become stiff and can get deformed. And not only that, they need to maintain muscle strength, so, and reduce stiffness. Okay. Now there can be various ways of giving physiotherapy, ultrasound, heat therapy, cold therapy, and you need to advise about joint protection methods and how to transform weight from affected joint to the other side, all these things. So that is why multidisciplinary approach with physiotherapists, occupational therapists, all these things are important. Okay? And you need to teach them how to utilize to get the maximum ability from whatever the functions left. Okay. And regarding splints and other appliances, occupational therapists will help the patient. Then dietitian will help the patient to have balanced diet and reduce weight. The drugs, mainly non-steroidal anti-inflammatory drugs, disease-modifying anti-inflammatory drugs. You might use steroids time to time and biological treatment. Non-steroidal anti-inflammatory drugs usually act through the prostaglandin synthesis system. Okay, you know the side effects. I'm not going to discuss these things. You have already learned in pharmacology. These are this you can go through the slides, and they cause action through arachidonic acid, and we prefer giving them COX-2 inhibitors rather than COX-1 inhibitors, because COX-2 will, if you inhibit, that will reduce edema, fever, and pain without side effects of COX-1 inhibition. So it's only if selective COX-2 inhibitors are preferred to non-selective inhibitors. Disease-modifying anti-inflammatory drugs are the mainstay of treatment of rheumatoid arthritis. They will delay the development of, they will reverse the disease process, reduce ESI and CRP, but their adverse effects can be higher. Okay. Now, the drugs that you use as disease-modifying drugs are anti-malarial drugs like chloroquine, then sulfasalazine, gold treatment, usually parenteral IM injections, D-penicillamine, methotrexate. Methotrexate is the commonest used drug now, and sulfasalazine. Then azathioprine, cyclosporine, cyclophosphamide-like cytotoxic drugs also might be used, especially when there is evidence of vasculitis and involvement of other systems. Okay, commonly used drug methotrexate given orally, once a week therapy, sulfasalazine again orally, given twice or 3 times a day. Hydroxychloroquine is given daily or BD. Okay. Corticosteroids you might use time to time at the beginning to reduce symptoms as a background therapy until the disease-modifying drugs start action. You might give a course of steroids. You might give time to time during exacerbations, but when the patient develops vasculitic manifestations, you might give large oral pulses or even intravenous pulse therapy in vasculitic involvements. And you might give intra-articular injections. And you might give, as I mentioned at the beginning, when you start the patient on disease-modifying therapy, until the drug start action, you give to suppress the symptoms and inflammation. Then there are biological agents. Biological agents, they are aimed at major histocompatibility complex, T-cell receptors and T-cells, and cytokines. Their mechanisms are TNF inhibition, T-cell cause. I think you know these things, you have learned immunology, so you know these things. Okay, so these are the actions of biological agents. And the commonly used biological, there are many biological agents. These are the commonly used biological agents, and we use mainly infliximab and rituximab at Peradeniya Hospital, but you might see in other various centers like renal transplant centers and various other places, these drugs are used. Then you might use high-dose chemotherapy with stem cell rescue, gene therapy in advanced cases, resistant cases, and all. Then even the surgeons can help Sometimes intra-articular steroid injections usually the physicians do, but arthrocentesis, that is the cleaning the joint. Then synovectomy. If the synovium is too overgrown with inflammation, you might reduce symptoms by doing synovectomy. Then if the joint is too damaged, you might replace the joint, or you might do reconstruction surgeries to reconstruct the joints. Or sometimes if a very painful joint, you can fix the joint to reduce inflammation, pain. Now, while you are assessing, now we discussed the diagnostic criteria, then disease activity criteria, but when the patient is in remission, you need to assess whether the patient is gone into remission also. How do you assess remission? The patient has morning stiffness less than 15 minutes. Now, usually morning stiffness would last the whole morning. Anybody can have morning stiffness for about few minutes, but if the morning stiffness lasts more than 30 minutes, it's significant. So if the morning stiffness reduces to less than 15 minutes, that indicates that there might be remission. And if the patient does not feel non-constitutional symptoms like he used to feel fatigue, then no joint pain, no tenderness, no pain during motions, no soft tissue swelling. And if the ESI is less than 20 to 30, then you think that the patient might be in remission, provided if the patient does not have unexplained recent weight loss, fever, or evidence of other vasculitis. Even if the things are okay, joints are okay, if there is evidence of vasculitis, unexplained fever, unexplained weight loss, those also can be due to active disease. Okay, I think I have come to an end. And if you are interested, this book is available at the Department of Medicine. This gives everything that you need to know about rheumatoid arthritis with all highlighted points, and it's at a very nominal price. Don't photocopy that. No point in photocopying. Book is you can buy the book rather than buying photocopying. It will cost you more. But what you need to remember is this book was printed in 2009, all about biologics, everything is there. Because of that, this book gives only about 2000 criteria, diagnostic criteria available at that time. 2010 criteria that I have discussed today are not there, but you can include from this lecture. Okay, are there any questions? Any questions? No questions. Okay, so please go through this, read a textbook and develop your own notes, read several times, then you will remember. When you see a patient, go to the patient and see whether these things are there. Okay. Okay, in that case, if you have no questions, I will stop the lecture. Okay, can I stop? There is no one to talk also. Okay, thank you for